Great. So thank you very much for that introduction. So I should start by letting you know I'm not a researcher. I'm not sure exactly what I'm doing here, but really what I'm hoping to share with you is, as a clinician, how research intersects with the work that I do and the work of my colleagues. We are trying to do a few research projects I'll touch on very briefly, but that certainly isn't my training. What I do in my day job is I see patients. I want to start by reminding you of an event in not so remote past in Canada, and this was really in the late 1970s when there were incursions by China into North Vietnam. And in response, the Vietnamese government decided to expel all ethnic Chinese. In the confusion that ensued, many people took the opportunity to try to leave the country. And there was chaos going on in Cambodia and Laos at that time. Over 2 million people were moving in Southeast Asia. And although the vast majority were moving over land, it really came to the attention of the West when we started to see boats like this, these rickety little boats in the South China Sea and pirate-infested, shark-infested waters. The government at that time, which was a conservative government, put out a call to ordinary Canadians and said, for every mostly Vietnamese refugee that's sponsored by ordinary Canadians, we'll match that. Within 2 years, 40,000 Southeast Asian refugees were sponsored by ordinary Canadians. And when the government saw that number, they said, okay, we'll take 10. They were shamed into taking 20,000. And 60,000 refugees arrived in Canada in the early 1980s. And I bring this up because to date, this is still one of the largest refugee migrations in Canadian history. But also, I would argue to you, this is the best studied migration. And really through the work of Dr. Morley Beiser, who is now here at Ryerson, but was in British Columbia at that time, he was able to follow people, over 1,000 people out over 10 years. And what did he find? Well, maybe it's counterintuitive, but what he found was that after 10 years, the rates of employment were actually higher in refugee populations. And quite interestingly, the rates of mental health issues were lower. And I think this really speaks to the power of research, really to flip some what might be conventional ideas upside down. What I do is I work in a refugee clinic where exclusively my practice is seeing refugees, but I want to back up about 5 years into really what was the scene here in Toronto in terms of seeing refugee patients. And I think there were tremendous gaps in care. What we were seeing is that although there were a lot of refugees and refugee claimants being seen in community health centers, I think the vast majority of them were getting episodic care in walk-in clinics and in emergency departments. So often that care was not in the language of people's choice. It was truncated care, was episodic, had very little follow-up. And I think this is a particular issue in people who arrive in Canada with often quite nuanced health conditions, not only mental health conditions, infectious disease conditions, but also many other issues, including dental health and problems with accessing contraception, things of that sort. The other thing that I think was going on 5 or 6 years ago is there was very little research around what was happening to refugees when they arrived here in Canada. So I had the privilege of being involved in a very large research project led by Dr. Kevin Potty in Ottawa, where we developed evidence-based guidelines for the assessment of immigrants and refugees. We looked at 20 different issues that confront newly arrived immigrants and refugees, and it was quite striking how little research there was on people who would actually come to Canada. So we were drawing upon research from the United States, from parts of Europe, New Zealand, Australia was starting to publish quite a bit, but we really had no idea on the people we were seeing here. What were their issues? What were they struggling with? What happened to them after arrival? And there was a tremendous gap in services. The other thing that I had noticed in my clinical work was there was a tremendous desire for students, medical students, nursing students, some researchers, to learn more about the issues that were confronting immigrants. So I think for that generation, perhaps a bit younger than me, they completely get it, right? To work as a clinician in Canada, in any urban area, you are responsible for the health conditions that people will see from anywhere in the world. You're responsible for understanding how to work cross-culturally, what to do when someone comes and sees you who doesn't speak the same language you do. They get it, perhaps much more so than people of my generation. So in 2011, Women's College Hospital opened up our clinic, the Crossroads Clinic. It's a tiny little clinic. It's modestly sized. It's 2 family doctors, so there's 2 of us. When I'm not here, our nurse practitioner runs the show. There's really only 2 of us there at any point in time. So we have 1 full-time nurse practitioner, 1 secretary. There's all 3 of us in 1 picture. There's our nurse practitioner. Vanessa is actually away on maternity leave. She's also our nutritionist. She is also our social worker. I was going to get a picture of her being our chiropodist, but she said, no, keep your shoes on. And the first thing we needed to address, and actually as I look back on it, this really wasn't an issue for us, is how do we reach out to the population? How do we reach out to refugees to ensure that we're serving their needs? Interestingly, and I think this is going to be a big part of the discussion today, this wasn't a huge problem for us. We spent a great bit of time reaching out to organizations and community that are already serving refugee populations. So we met with the United Nations High Commission for Refugees, we met with the Canadian Council for Refugees, but more importantly, we went to the ground for to really meet with the people who are seeing and working with refugees on a day-to-day basis. And this was the refugee shelters. So we have a very strong relationship with 5 of the largest refugee claimant shelters and the one big shelter that sees government-assisted refugees here. These are people who know their clients on a day-to-day basis. They live with them. And since the point that we first opened our clinic, we now have 2 small clinics located in the largest refugee shelters in Toronto. So at the Christie Refugee Welcome Centre, which isn't far from here at Christie and Bloor, and at Sojourn House. Sojourn House sees about 600-700 refugee claimants coming through there every year. Christie sees about 400 or 500. So we are where people live, right? And so often we'll see people walk by with their child once and they'll look in and then they'll walk by again and then they stop the 3rd time and say, oh, my child has an earache or they have pain. And I think just being in an environment where we can overcome those barriers to access has been very fruitful. When people leave the shelters, we'll follow them up at the Crossroads Clinic here at Women's College Hospital. So what did we struggle with? Now we're here, most of you I assume are researchers. As a clinician, what we need is data. We have, often we are seeing refugee populations arrive here. We have no sense of what their issues are. We often turn to the lay literature. And I'll give you one example. In 2009, 10, 11, the largest source country for refugee claimants to Canada were the Hungarians. And most of those people were the Hungarian Roma. We quickly started looking into the literature there. And we were seeing very high rates of sexually transmitted infections, very high rates of HIV. That hasn't been what we've seen here. We've certainly seen a lot of chronic illness. Most of the research we were relying on was from Europe. Most of it was on the Romanian Roma, not the Hungarian Roma. Obviously, 2 very distinct populations. And I would argue the research that we're starting to do in our population not only should be done to guide clinical care, but so often we're seeing a level of discourse around refugee migration that paints refugees as people who are here cheating the system. You've heard the term bogus refugee. And more we're recognizing the need to do research, good research, but to do research that also speaks about advocacy around migration. We need improved capacity. Everyone speaks to this. There's very few clinics like ours across the country. There's thousands of people arriving. And we need help with transition from specialized services. So our model at Crossroads is to see people for 2 years. Then we actually find physicians for them in the community. And we chose 2 years because at that point, we're hoping people will be competent in English. We hope that the refugee processing system will have been undertaken. People will have OHIP. And then many of those tropical diseases, I think, scares a lot of family physicians, will have been dealt with. More and more, we're finding advocacy to be a significant part of our work. This is advocacy around getting people access to care and getting people health insurance. And we're looking at this in terms of research as well, in terms of documenting what we're finding and people's perceptions to some of the cuts that we're seeing out there. I'm going to finish with a quote from Elie Wiesel, a Nobel laureate, a survivor of the Nazi concentration camps, who said, "Today as yesterday, a nation is judged by its attitude towards refugees." Thank you.